Welcome to our very first NCAS webinar this year. We have a fantastic lineup of presentations, and we've actually a priori decided the key topics that we think you'd like to hear about. So kicking off this morning is a very special seminar that I'll ask Ruby Biezen to present. First of all, before we start, I would like to acknowledge the original owners of the land and their elders past and present, just to take a moment to reflect on that. We know that one of the areas of need really in stewardship nationally in Australia is in our primary care. There are many issues trying to get it underway, and so we're very thrilled to have our international speaker this morning, and I will ask Ruby to introduce Alastair and welcome you all.
Hi, welcome everyone. My name is Ruby. I'm from the Department of General Practice at the University of Melbourne. So I'm actually privileged, it's my great privilege to introduce to you Professor Hay. He's from the University of Bristol, and he joined the Centre for Academic Primary Care at the University of Bristol in 2001 and was awarded his MD in 2003. Since then, he's actually led the infection research group, which conducts multidisciplinary research to improve the management of acute infection and the use of antibiotic in primary care. So he's going to be talking to you about improving the care of children with acute infection and stewardship and stewarding antibiotics. Is it too much to ask? So please join me into welcoming Professor Hay. Thanks.
Sorry, they just get me for a brief moment in time while I sort out how to share. Yeah. And then go.
Alice, do you happy that we record your presentation
Yep.
this morning?
Yep.
So we do record our presentations and pop them up on the NCAS website.
Okay, got a global first going on the website.
Yeah. Could I just ask one of the attendees to confirm that you're seeing the actual slides and not presenter mode when I've got the screen sharing function on? Oh, yeah. Oh, Judith, is that okay? Is that working correctly?
Getting a thumbs up.
Oh, that's a thumbs up.
Oh, good.
Perfect. All right, we'll take it at that.
Speak now or forever?
Yeah, oh, that's it. It's because
Please.
it's a webinar. They don't get the freedom to talk. So, all good. All right. So,
Are we good to go?
yeah, have a seat.
Thank you.
How's Alastair?
Thank you so much to NCAS, CAS, for the warm welcome and the opportunity to talk to you about this subject today, and of course to Ruby for hosting me for the last few days, and for that very kind introduction. And I understand there will be perhaps how many people?
We've got about 20 online at the moment.
Great.
Yeah.
And I understand that we'll have a mix of professions, so pharmacists, veterinary scientists, possibly some vets.
Yeah, we've got some vets in the room as well.
Some primary care folk, so maybe some doctors and nurses, maybe some secondary care folk as well. So paediatricians. So my kind of slant is very much from the community angle. And as I was just saying to Ree, thank you, Ree, as a GP looking after children, I think we'll perhaps have some similarities occasionally to looking after animals. So let's see if we can progress these slides.
Should just go like that.
Let's just try here. Yeah, fine, great. So the outline of the talk is, we'll get the slides to move along in a minute, is I will do a quick brief introduction where I've come from, add a little bit to what Ruby's already said. I will provide 3 clinical vignettes. So these are children commonly seen in primary care with common problems. And then I'm going to sort of present some of the recent research that we've done that might underpin perhaps an improvement in their care, and possibly included in that some improved antimicrobial stewardship. I'm planning to talk, I think we've got about an hour, and I'll stop at about 40 minutes. Is that about right?
Sounds good.
So that there's plenty of time for us to have some discussion. And then those of you who can stay, I've promised an extra special seminar just to the NCAS folk that will follow this. I was born in New Zealand in 1967, so you can do your maths real quick. Shipped to the UK.
It's saying it's in presenter mode online, but oh yeah, slides are in presenter mode. Okay, we might just have to have
It's a display setting.
yeah.
That one.
If it does, but then then these guys just see it. That's fine. That
Yeah,
just means
that'll
that
be
people
okay.
online, but then you can still,
We
yeah,
can still-
that's fine. It's all us.
So keep
Thanks,
on
everyone.
shouting if it doesn't go right. So born in New Zealand, shipped to the UK, eventually decided I would love to be a doctor, trained at Sheffield Medical School. So that's one of the buildings in Sheffield on the left there. Dillied and dallied with different sort of types of doctoring, including a little bit of pediatrics, which I was privileged to do at the Starship Hospital. That's the picture on the right in Auckland. And then finally saw the light and decided that general practice was for me. At which point I started to, these are a couple of the practices I trained at in Sheffield. At which point I decided a little bit off the hoof that I was going to be an academic. I'd done zero research at that point, but managed to secure a 4-year post at the University of Leicester that allowed me to do 50-50 clinical and research. And as Ruby says, I then moved to Bristol in 2001, and I've been Professor of Primary Care since 2013, and that's my office back in Bristol, which has been an extremely productive and happy place. So I lead the Centre for Academic Primary Care Infection Group. And this is a slide that we often sort of show one another because it provides, if you like, the structure for the research that we do around the patient pathway to ultimately receiving antibiotics and then being at risk of becoming or acquiring antimicrobial resistance. This is not rocket science. This is not supposed to be hugely clever, but what it is supposed to do is get us think about which part of the pathway to antibiotics is any one given project concentrating on. So on the far left, you've got the acquisition and transmission of infection in the community, which we are all subject to. That's the 100%. We all of us fall unwell, at which point we have self-care opportunities, which I think we should encourage our patients and our owners of pets to do as much as possible. At some point, some of us decide to seek help from our healthcare system, and we've got very little evidence as to exactly what proportion that is. The best we can come up with at the moment is it's somewhere around 8 to 12% per infection episode. So the bad news is that leaves a lot of people out there who are currently not seeking help. And if we are very unwise, we're going to find ourselves inadvertently promoting them to attend for care as well, which is just going to increase demand. And clearly demand could increase 5-6-fold without any trouble at all. Having made it into the primary care clinic, then a decision is made regarding the use of antibiotics and increasingly in the future antiviral treatment, which might include a number of different tests, including possibly point of care tests. And those red circular arrows indicate that the more we do at this point, either by way of prescribing or testing, the more we reinforce the idea in the patient or the vet owner's mind that they did the right thing, they sought help, and that they should do that again in the future. So we have the opportunity to lengthen and harden the rod for our own backs, if you like, from that point of view, a vicious circle. But the good news is we can also turn it the other way, and it can become a virtuous circle if we get this right. The antibiotic has been prescribed, and then the arrow going north talks about the pharmacy role, which of course can also be in the face-to-face or patient assessment. who then will dispense the antibiotic. The patient then decides whether to collect that prescription and whether or not they're going to swallow it. And then finally, that puts them at risk of AMR, which is that red box on the right. Of course, there is the role of the hospitals here. And again, we don't know a great deal about the proportion of people who have presented to primary care who then end up in hospital, but we think it's somewhere around 1 to 2%. And that's clearly an important group from antimicrobial stewardship point of view as well. And what this slide doesn't do is it doesn't present the One Health picture, but I hope we can sort of see that embedded here. So this slide just shows 1 or 2 of the studies that we have been doing over the past 25 years or so, and where they have fitted in. So just as an example, on the far left, the EFRE-C study is a current randomized controlled trial, which is putting air filters into care homes to see if that reduces infection transmission and incidence of respiratory infections. Just to give you another example, on the far right top, Rapid Test is a current randomized controlled trial of the bioMarow BioFire platform placed in primary care clinics to see if that changes antimicrobial prescribing and also antibiotic consumption. And also, if it does do that, how it's doing that, because that's a really important question for the research community as well. And then there's this box here, the circle there, which is just highlighting the relationship between primary care prescribing and resistance. And we're not going to talk about that today now, but I'm going to offer a little extra to the NCAS group later about that. So Emily has been unwell for 5 days. I think you can tell that she's coughing, she's snotty, she's got discharge coming out of her eyes. In fact, every place you can think of, she's discharging. She's feverish, and she is a human microbe transmitter. She's just the perfect transmitter of everything. And she represents the most common clinical scenario that is faced by GPs worldwide, an acute respiratory tract infection with cough. So I set about in my very first study, which is represented here by this ancient Ford Fiesta. This was a study I did for my MD to establish how long that presentation, how long that illness lasts. Because I was hearing my colleagues say to parents, it lasts about a week. And I was thinking, I just don't think that's true. My experience as a parent doesn't relate to that. I think it's longer than that. So I recruited the children. I invited them to complete this symptom diary, which they did beautifully for me. And this was the final result. And as you can see here, this is a Kaplan-Meier survival curve. The y-axis shows the cumulative probability of recovery, and the x-axis shows the duration of illness, or particularly cough. So this is the point at which cough has fully resolved. And as you can see here, it's about 7 days for a quarter to have recovered. It's about 2 weeks for 50% to have covered. It's about 3 weeks for 3/4 to have recovered. About 90% have recovered somewhere between 3 and 4 weeks. Now, what's the most useful metric to tell a parent? I would argue it's the kind of 90% recovery rate. If you give them the median, well, 50% of them are going to be knocking on your door after a week saying, why is my child no better? If you give them the 90%, then you're on safer ground. So now I think commonly, and I think this is increasingly the case in the UK, GPs are saying you should expect this to last 3 to 4 weeks. The other thing I did in this thesis was, at the point where I recruited them, I asked both the parents and the clinicians to predict how long that individual child's illness would last. And as you can see here, both the parents and the clinicians tended to assume a faster recovery than was actual, but the parents were less inaccurate than the clinicians. So the clinicians, if you like, were definitely underestimating illness duration, as I had thought. And that went on to receive a number of awards, and ultimately we repeated that work as a systematic review, which was published a few years later in the BMJ. So moving on then, that was, if you like, the foundation stone for some of the work I would do later. And we were still kind of grappling with this question of why are the GPs prescribing so many antibiotics? And one of the things we established was that their concern was to do with being perceived to have undertreated the child who subsequently deteriorated. That never looks great. You could be, at worst, in court, medical legally, but at best, you've still got unhappy, disgruntled parents saying, well, why didn't you give them an antibiotic? And for the most part, that means clinicians will, if there's any uncertainty, if there's any kind of deliberation, it's just safer to prescribe. You know, it's one antibiotic. It's about £1.10 for an antibiotic course. All of that saves a huge amount of hassle. Brackets, even if it doesn't work. So that got us thinking about, could we identify amongst all of the thousands of children that we see every day in our clinics, could we identify the children most or at least risk of subsequent deterioration? And we successfully secured funding for that. It was an enormous effort because the sample size calculation told us that we needed in the order of 8,000 children, which we successfully recruited from just under 250 GP practices with 671 clinicians helping us. And then we looked at whether or not the child was hospitalized for a respiratory tract infection by looking at the notes. We did a notes review. And the notes review is great because you get complete data. So we get 100% outcome data for the primary outcome. Just under 1% of children were admitted. So that's 78 out of the 8,000. And these were the discharge diagnoses, which, although this is not particularly secure, you can nonetheless see that there are quite a high proportion of these that you would not expect to be modified by an antibiotic, even if one had been prescribed. We then crunched the numbers and established that there were 7 factors that were each independently associated with an increased probability of subsequent admission with reasonable discrimination when bootstrap validated ROC, area under the ROC of 0.82. And those factors we then put into a mnemonic which we called star wave. Now, if you assign 1 point per item, you get pretty much the same discrimination as you do using the coefficients. And that makes it much simpler to use in the clinic, of course. So a child with none or one of those 7 features has a probability of being admitted to hospital in the following 30 days of less than 1 in 300. And that's the majority group. If you have 2 or 3, then you're, if you like, in the medium risk group, which is pretty much unchanged in terms of your overall probability. It's somewhere in the region of 1 to 2%, which is not that far off what the pretest probability for the whole cohort was. And if you've got 4 or more, then your probability goes up to somewhere around 10%. Now, that's not high enough to be clinically useful. 10% post-test probability for a clinician isn't going to help. So it's not that we can actually say this is a rule-in test, but it almost certainly is, we think, a rule-out test. And given that the majority of children are in that 0 to 1 group, if we could reduce prescribing by increasing that confidence in that group, then we would make a substantial difference. And in fact, this is just a kind of model of what would happen if prescribing in the low-risk group fell by 50%, prescribing in the middle group stayed exactly as it was, and prescribing in the high-risk group went up to 90%. You'd still get a 10% overall reduction in prescribing if that was to happen. That was then published in Lancet Respiratory Medicine. And of course, the next step is to do the randomized controlled trial to see whether this does make a difference or not. And this was, first of all, put to the test with a feasibility cluster RCT, and it was just as well we did because it was a bit of a disaster. What we did in this feasibility study was we consented the individual children because we wanted to look at their notes to establish whether or not they had had hospitalization. And the problem with consenting participants after you've randomized your clusters is that they know which group they're in. And then you run into the problems of post-randomization recruitment bias. And that's exactly what happened here. We found a paradoxically higher prescribing rate in the intervention group than we did in the control group because there was a difference in illness spectrum between the two groups. So we thought, fine, we've learned our lesson, we won't do that again. We went on to seek funding to do a different design, but still a cluster randomized controlled trial. This time, not taking individual participant consent, but using routinely available data to establish whether antibiotic dispensing had changed, and as a safety measure, because we wanted to establish whether we were doing harm and whether children could be undertreated and that could lead to them being hospitalized. The other outcome we selected was hospitalization. And there were other secondary outcomes that included emergency department attendance. The intervention had three parts. So the first part was around eliciting the parents' concerns. The second part was around the use of that prognostic star wave algorithm. And then the third part was a personalized leaflet for that child, which included safety netting. The algorithm was put into the electronic medical record so that it generated the scores automatically. But the idea was that it would still be discussed within the consultation. We worked with EMIS, who is one of the two majority providers of electronic medical records in the UK, and they were willing to provide what we call a soft pop-up, which is that bottom right hand there. So that's when a child came in the room. Now, you don't want to have a hard pop-up for every child because there'll be children coming in with things that are not relevant, and that just irritates. So the soft pop-up comes when the child's record is opened, and then there's a, as it were, hard pop-up comes when the clinician enters a relevant diagnostic code. At which point they then ensure they've entered the data, and we know they've entered the data. So we know the number of times the algorithm was used. So these results are currently under review with the BMJ. We've been through a third iteration of reviewer comments, so we're kind of holding our breath that they might be reasonably happy.
And we can share this once it's published. Like we will put this on the website.
That would be
we'll
great.
wait for you to let us know.
That'll be great.
We'll wait for the good news.
Thank you very much. So we recruited from around England. I won't go into the details of the sample size calculation. They're not in my head, but I can find them if you want to know. We think we needed around 300 GP practices to be randomized, and we secured 294. The intervention practices provide us with reasonably complete data about the number of times the intervention was used. And you'll see here that we think it was used just under 12,000 times, median 70 times per practice by 1,400 users, mean 9 times per user. So reasonable use. And of course, the more it's used, the more opportunity that the clinician can actually remember the mnemonic. And so even if they weren't using the template, they could still have been using the mnemonic. Most of the clinicians in the intervention group using the template were GPs, but a quarter were other healthcare professional groups. So, big reveal, the results, dispensing of antibiotics. This was pediatric formulations of amoxicillin and macrolide. So would you like to hazard a guess? Do you think that this changed antibiotic dispensing? Getting a kind of mix of...
Get doctors to follow decision support.
Yeah.
It would be depending on the sort of person.
Okay, so mix of views, but possibly more skeptical than positive, which is fair enough. So the trial ran into COVID. And what you'll see here, this is just overall dispensing, and those pink bars are the periods of lockdown when, as we all observed, infections just dropped off in terms of incidence, and so did presentations to primary care. And when they did happen, of course, they were no longer face-to-face. And this was a mnemonic, which, although we sort of thought it could be adapted, really it was designed for face-to-face use. So this is the graph showing the dispensing. The red line on the graph is the intervention group dispensing rate, and the blue line is the control group dispensing rate. And as you can see, they more or less track one another line for line. So you won't be surprised that the stats, when you crunch those, the numbers demonstrate that visual impression that there was no evidence of a difference between the two arms. Now, we did do some subgroup analyses, and there's an interesting kind of dilemma around whether you can call a pre and intra-pandemic subgroup analysis a post hoc, or you can't call it a pre-planned one because the COVID hadn't happened. So this was a post hoc one. But actually, we did see reduced prescribing in practices and at sites with those conditions, including, in fact, some evidence of a difference in the pre-pandemic period. So possibly some hope, but we're always clinging to hope, aren't we, us researchers? Okay, second then, hospitalizations. Do we think it made any difference to hospitalizations?
Not during COVID.
And overall?
How do you link the hospitalization for it to be sort of bad and not COVID?
Because we can, yeah, we know which practice the child's come from and whether they had attended or not. So again, here you have the overall graph and the depression of activity within lockdown. And here you can see once again the lines tracking one another in terms of hospitalization rates in the intervention and control groups. And again, the numbers confirming the visual impression from the graph. So no evidence of a difference in the rate of hospitalization. The sample size calculation for this was actually a non-inferiority based calculation, and it did meet our non-inferiority criterion. So, you know, I think we can at least conclude we weren't doing any harm.
That's important.
This is A&E attendances, and you're going to see a similar set of figures and patterns here. Again, mapping one another very closely, and again, the numbers demonstrating no evidence of a difference. So all a little bit disappointing. We're waiting with bated breath to see what NHS England does with this and how they decide to use it, whether they think there's enough there for them to recommend the star wave mnemonic algorithm and the other elements of the intervention to be used. Do we repeat the whole exercise again? Do we have the energy? Would the funder have the appetite? I don't know. Possibly not. I think there may be other fish to fry. But let me just pass on to another element here, which is a
Can I say something?
kind of good news story.
What it shows is, you know, that we always talk about, if we're following the traditional randomized controlled trial methodology, just how long it takes to go from one end to the other to actually generate change. We need to be doing things a bit smaller.
Yeah, we do. I mean, this is
Classic example of all this long, how many years? Like
1997 I started this.
Yeah.
25, 26 years.
Amazing.
Now,
Because the data's all there, right? The signals are all there. It's around implementation.
should we pause that, come back to that? Because we can, I'd definitely be interested to hear your thoughts on that. I thought I might just tell you about this other study. Now, as an MD, PhD student, I wanted to change the world. And the first grant I ever wrote was a placebo-controlled trial of amoxicillin for children with cough and RTI. And that ended up being done. So that wasn't funded, no big surprises. I didn't have the track record. I didn't have the experience to lead a big RCT in primary care, but I had the ambition. And I worked with a colleague and friend, Paul Little, and he and I ultimately got this study funded, and it was published last year in The Lancet. And what it shows is that for a group of children aged between 6 and 12 months who've got acute uncomplicated lower respiratory tract infection but no suspected pneumonia, if they're given a reasonable dose of amoxicillin, and then the main outcome is how long their symptoms last at a moderately severe or worse level, and if you randomize the appropriate number of children, then this is what you see. You see that the lines overlap and that there's really no evidence of a difference in recovery between the two groups. If there is a difference, it is very slightly in favor of the antibiotic, which is a pattern we see over and over and over. There is sometimes a small difference, but the question is it clinically meaningful? And then the other question is, amongst these groups of patients, is there a subgroup who are buried in there who are particularly more likely to benefit? And this study, we looked at that subgroup question because we were interested to know whether when the GP saw them, there were abnormal chest signs, if the parent had reported hearing phlegm or seeing phlegm, if the child had had a fever before presenting, if the physician thought they were more unwell, if the parent had reported shortness of breath, if the oxygen sats were low, and also we looked at the impact of star wave, would any of those subgroups differentially benefit from antibiotics? And the answer is no, they don't. So all the common reasons that a GP would give for prescribing an antibiotic to a child with acute RTI and cough, like I could hear a rattling noise in the chest, they don't denote any differential benefit to amoxicillin when compared with placebo. Now, in terms of time, shall I just keep going a little bit longer, or would you like me to stop? No, fine. So I'm not going to go into quite as much detail for the next studies, but I just thought I'd tell you about a couple of others. So Miranda has a fever. And again, you know, this is just bread and butter kind of primary care. The number of parents who call us about fever are concerned about fever. And the NHS wanted to know whether children would benefit from the use of 2 antibiotics versus 1, because they were hearing reports of parents starting to use ibuprofen and paracetamol at the same time. No big deal maybe, but they still wanted to know whether that was useful or not. And we responded with the Pitch trial. This is Pitch the duck. He does look like he's smoking, and you know, we all kind of live and learn with our logos, but that's supposed to be a thermometer, and he's supposed to be looking unwell with a fever. So we randomized children to receive either paracetamol and ibuprofen. And ibuprofen, or paracetamol and placebo, or ibuprofen and placebo. So it was blinded. They didn't know which group they were in, one of 3 groups. And we asked the parents to help us by encouraging the child to wear a bespoke vest which had a little data logger in it. And the data logger had a little lead that led to a thermometer that was stuck using micropore into the child's axilla. And this measured the child's temperature every 30 seconds. So it gave a really sensitive readout as to the child's temperature, which meant that we got this beautiful graph over 24 hours. And what you can see here, red line is paracetamol only, orange line is ibuprofen only, and blue line are the 2 agents together. And it's clear, and the stats bear this out, that if you give ibuprofen with or without paracetamol, the fever comes down fastest, comes down faster than with just paracetamol on its own. After that, there isn't too much to split between paracetamol and ibuprofen when used individually. But if given together, the temperature does stay down for longer. And that's basically what the stats tell us. And that was subsequently published in the BMJ. final then study here is little Sophie. Anyone want to hazard a guess as to what her diagnosis is? She's not just had her teddy taken away, this is earache. And what do children with earache need? They need pain relief. What do they not need? Why are we using antibiotics in children with otitis media? The parents are desperate for something and the GP feels sorry for them, and that's their token of sympathy. But, you know, that's just a ridiculous way to work when the child actually just needs some decent pain relief. Now, Penny Bolt, who's a colleague of yours in the Children's Hospital in Melbourne, published a lovely paper a few years back demonstrating that lignocaine provided superior relief to placebo when given topically as an eardrop. Now, she did that study in the emergency department. Nobody had ever done that study in primary care, and no one had ever done it using repeated doses, which is what parents would do in the real world. So that's what we, without perforation. So that's what we set out to do. And we randomized children. The koala, you can just see his right ear is sore, and I've heard all about chlamydia and koalas. So you know, again, we didn't choose the koala thinking I'd come to Australia in 2023. But we let me move on from that one. We randomized children to receive oral GAN. Now you can buy oral GAN here. It's made by Pfizer, and they agreed to supply it to us from Australia. I went down to check, and I think $12.99 buys you a box of oral GAN. So we had intended that children would be randomized to either receive the oral GAN or a placebo drop or usual care. And the primary outcome we thought long and hard about, but we decided the most important outcome of interest was whether or not the child consumed an antibiotic in the following 7 days. And a key secondary outcome was pain. Now, this trial ran into all sorts of trouble. The scars are visible on my back. The company that agreed to produce and supply the placebo didn't produce or supply a placebo. So for the first few months, we were randomizing children to oral GAN versus usual care. Eventually, the provider did bring some placebo to us. The lids were falling off when it first got to us, so we sent that lot back. Eventually, we did get some placebo. So we did finally randomize a few children into the 3 arms, but you can just see it was just going belly up here. It was just not going well. The numbers were a lot smaller than we'd ever hoped. So 74 children were entered into the 2-arm part and 32 into the 3-arm. And, you know, we did the best we could with what we had. It appeared clear that children receiving active drops were given far fewer antibiotics than children receiving either usual care or placebo. So it looked like there was a pretty good going signal in terms of antibiotic consumption. Of course, the placebo comparison was the key one for pain, because this is parent-reported pain and knowledge of group was going to make a big difference. So we didn't have enough data to really look at that, but there does appear to be a wee bit of a signal in favour of active drops compared with usual care. So not great. Sorry, guys, that's got to be one of my biggest disappointments, because I reckon that would have been heading towards the Lancet if we'd completed it as planned. But you know what? NICE has changed their guidance. On the back of this trial, they think that children should be offered an anaesthetic eardrop now in the UK. So who knows what constitutes success and what constitutes failure. So improving the care of children with acute infections and stewarding antibiotics, is it too much to ask? Well, why don't we talk about that? Still to come, I'm giving a public lecture tomorrow at 6 o'clock in the Prest Theatre. If you guys come, that'll make 14. So it would be great to see you there. And if you are going to stay on, I'll talk a little bit about our work relating primary care antibiotics to antibiotic resistance. Thank you so much for this opportunity.
I will just check. There's
Well,
a
yes,
couple in
you're
the
right. The taxi driver said he would come.
Q&A. Oh, yeah, Kaz has put, please post your questions into this Q&A. So, whilst we wait for some online questions, are there any questions in the room?
It's more a comment.
Yeah.
Just how it is just very impressive to have undertaken 3 randomized controlled trials. It's not easy in primary care to do randomized, and I think anyone online, you know, comparing that to doing something in a hospital setting, you know, it's really hard.
Is in the UK. That first study I did with the old banger Ford Fiesta, I was doing, I think, something closer to what you guys are doing now. I was phoning up the practices, I was speaking to the practice managers. I was saying, would you mind if I come and talk to the doctors about this study? Might they be interested? All of that. And then I went in and recruited all the participants myself. Now, when we have a study, if it's NIHR funded, that means it's eligible for NIHR Clinical Research Network support. And in primary care, that means we can go to a really quite well-established network, and they interface with the practices for us. They, if you like, sell the study. And once a practice has indicated they're interested, then we kind of take it, the study team takes over at that point to just really check they really know what they're in for and what the study involves, and then do all of the site training, etc., etc. It's just worth saying that not all sectors are like that, and with the care home study, the air filter study, which is actually going remarkably well, it reminds me exactly of doing the research 20 years ago in primary care. It's more or less where primary care was 20-25 years ago.
2 questions. Leslie Halls, who's one of our postdocs, did a primary care AMS PhD. She's asked about the guidelines, how are they accessible to the prescribers, how are they implemented, how often are they maintained? Is the NICE group a parallel group to other guidelines? Like, what is it that your GPs use?
Yeah, it's a good question. Mostly I would say nothing. So if you talk to GPs about guidelines, the older GPs particularly will go, you know, I don't need guidelines. I know what to do. I know, don't tell me how to manage patients. I've been managing patients for 30 years. I think if you talk to the younger clinicians, they are a little bit more embracing. And I think many of the medical students use NICE and its kind of parallel body clinical knowledge summaries, CKS, as a really important resource for learning. So I think there's a generational gap in terms of attitudes towards NICE. NICE is the body that provides guidance to England and Wales. Now, that leaves Scotland, which has its own guideline process called SIGN. And sometimes they'll see sense and work together. Sometimes they'll produce separate guidance on the same thing, but then, you know, they're looking over each other's shoulders the whole time to make sure that they're saying something similar. In terms of actually accessibility in practice, I don't think we're nearly as close as we should be. So at the moment, if I want to check a guideline, I have to open another page on my web browser and go into it. But a number of us have been saying to NICE for quite a long time, get it embedded in the electronic record, get the appropriate guideline to come up when the diagnosis is put in, make it a one-click thing, and then you'll get people to use it much more. In fairness to NICE, with the latest antimicrobial stewardship guidelines, and I've been part of that committee, we've now started producing what we call visual summaries. And those are literally a landscape piece of A4 that summarizes everything you need to know about the guideline. A second page which goes into the antibiotics if you are going to prescribe. But the first page is really all about not prescribing unless it's necessary. So do you get access to them, or do you get blocked if you try and access NICE guidance from here?
No, we can get them.
Yeah.
They're rather monolithic though.
Yeah.
You sort of you go down a rabbit hole going, oh,
Yeah,
and you go,
yeah.
where was I at the
Yeah.
start? And
Yeah.
so
They-
they're really good, but they're monolithic.
Yeah.
It's a different focus. It's very impressive what NICE do, and it's much more rigorous. It's not about rigor, but the way our therapeutic guidelines, they tend to be done through writing groups, and they update them. They do not follow an agreed framework or an evidence-based framework. It tends to be a consensus approach. They definitely have a focus on embedding AMS principles into them, but because of the fact that they followed a consensus approach, it would be fair to say that there have been elements there are still elements that are controversial every edition that comes out. So the dentists, for example, were very put out by the antibiotic guidelines for dental infections because they're actually written by an adult ID physician as the lead rather than the dentists themselves. So they were involved. So it's continually improving. It is a live document now, so they will use our NAPS data. We can feed back our NAPS data and they will take that on board. For example, a few years ago, there was very high rates of the macrolide use for hospital-acquired pneumonia in the NAPS, and we fed that back. So they were to explicitly put a statement in.
That's good.
In public hospitals, there's free access through this clinicians' health channel, but GPs, I think you heard now that they have to actually pay a small fee to access the guidelines, and they're not seamlessly embedded into the practice software. And in fact, what we found through the GP NAPS project was that they actually preferentially go to MIMS, which is not a guideline. So they were fantastic for indication choice and dosing out of the MIMS, 85% compliance, you'd be pretty happy, right? But only 30% compliant with BTG. So I think you're right. We need to be leveraging the technological infrastructures to support them through bringing information together, providing decisions at the point of care, and at least getting some audit and feedback to them so you don't know how they're going. I think.
Crucial. As I was saying yesterday, I don't know if I'm a high, medium or low prescriber.
Yeah,
I don't know if I prescribe too many broad spectrum antibiotics.
yeah,
I mean, isn't that ridiculous?
yeah. Ruby.
Another question going back to recruitment. So you've got these group recruiting practices for you, but once you actually in the practice, how do you identify the patients?
Depends on the study. So in the large RCT where we were looking at dispensing and hospitalization, that was all done through the clinicians identifying the relevant patient, putting in the right code, and then the pop-ups coming up. So that's a light touch, if you like. If it's a much more intensive study, so rapid tests, which is where we're looking at the BioMero BioFire platform, that's a really complicated study. And we've said to practices, we only want you if you've got quite a lot of research experience. And we've asked them to identify 2 people. In fact, we've asked them to identify 4 people in each practice who will support the study, and they'll work as 2 pairs. One of the pair will be what we call a study champion, and the other of the pair will be what we call a study clinician. And the study champion's job is to literally look at the list of patients that are requesting appointments for that day to see if any of them look like they might be eligible, and then sending them the information about the study so that the patients are pre-warned, that they know that there's a potential for them to be invited into a study, they can be sent the patient information sheet so they can start to read it, start to make a form of view as to whether they're interested or not. Then when they come into the practice, they'll hopefully be met by the study champion, who can even go through almost to consent them. They can't quite establish eligibility in that study because there are some clinical ones that will only be apparent once the clinical assessments happen. So then the study clinician sees the participant, confirms eligibility, confirms they want to be in the study, and then either takes consent themselves or sends them back out to the study champion so that the study clinician can get on with their clinic. Study champion then consents them, takes a swab, randomizes the patient, and then if they're randomized to intervention, gets the swab to the biofire machine and processes the swab, telling the clinician what's happened all the way along, because if they're randomized to control, then the clinician can just finish the assessment, the management plan there and then. Once the biofire result is ready, feed that back to the clinician, who can then phone the patient back up and say, we've made the final decisions now, this is what I'm thinking, blah, blah, blah. All along, the study champion is checking that the GP is entering the data, because GPs won't enter it unless somebody's pounding them. So, that's a very labor-intensive design, but that would be on one end of the spectrum, whereas the dispensing study is on the other end of light touch recruitment. And we would pay the practices for that. So we kind of work through how much time is each individual staff member spending. So reception, admin, nursing, HCA, GP, and that ultimately leads to a kind of per participant recruitment fee that the sites would receive. And in the rapid test study, that's about $400 per participant. Yeah. And that reflects the amount of time they spend. It's not that we're kind of being overly generous, although we try and be a bit generous. Yeah.
You don't pay the patients though, but there's no.
We don't pay them, but we offer them vouchers and thank you things. And we offer to send them results at the end of the study. Sometimes we might even offer to give them their own results at the end of the study. So we try and make it of interest to the patients as well.
Another question from Mignon, who's up in Queensland, about have you evaluated the role of multiple interventions? Because obviously no one single thing is going to be effective. So thanks, Mignon, but also Laura, it might be helpful to hear about the approach that you did in vets, about a stepped approach around how you did that, because the Green Cross trial was very impressive.
Yeah. So we had 135 veterinary GP practices around the country that we included in our trial, and we had 3 levels of stewardship, I guess. So one was education only, so we gave them all a guidelines poster, and we ran a webinar series over 12-month period, about, I think only 10 months, but where there was 8 webinars on very syndromic, mostly syndromic topics that we knew there was a lot of inappropriate prescribing for. So urinary tract infections, dermatitis, particularly in dogs. But then we also did one on infection prevention, and we did one on delayed prescribing as well. Because vets do a lot of informal delayed prescribing. And so that was our education only group. And then we also had 2 intervention groups. One was kind of a medium intensity. It had some visual reminders like a traffic light system for antibiotic importance, because all vets dispense their own medicated like antibiotics, and so they all have a pharmacy within their practice. So we just got them to label on the shelf where the antibiotics were, whether they were green, orange, or red, high importance. And we had those medium groups had a champion, and they used some diagnostic testing guidelines. So for urinary tract infections, the guidelines recommend a cultural susceptibility at the first presentation, and so we had those sort of some guidance around when to use diagnostic testing. And then in our really high intensive group, we asked them to restrict the high importance antibiotics, which is mostly in vet, it's enrofloxacin and a third generation cephalosporin called cefalexin. So we asked them to restrict those. And we also had audit feedback in that group. We asked them to keep track of their antimicrobial resistance and do a few other things. So, and then we evaluated it in 3 ways. We had the antibiotic use data from these 3 practices, which we had a PhD student working with us who was also a vet, but also a data scientist. So that was, we were pretty lucky in that regard, because veterinary data is messy. And so we were able to look at the antibiotic use over 2 years before the trial, and then for the 2 years that kind of the year that we implemented and did the webinar series, and then the year after. So when we really were hands off, and the practices just did their thing. And then we did a survey where we got about half of the vets that were participating to complete the survey, and one of our master's students also interviewed some vets, some of the management, and then the chief veterinary officer, and she also interviewed some of the practice managers and that sort of thing as well.
Very impressive.
So it's very complex, but we saw overall, we saw about a 50% reduction in antimicrobial use in the intervention phase and the post-intervention phase. It was dropping before the trial started. So in the pre-trial period, we had a 13% reduction over the 2 years of the pre-trial period, but it definitely got faster. And we saw in the most intensive group, we saw a bigger reduction in the use of high importance rated antimicrobials. So there was 25% less high importance rated antimicrobials used in that group compared to the education alone group. And there was we were able to demonstrate a small impact in terms of overall antimicrobial use in both the intervention groups compared to control. But then in the survey that we've just got really great feedback. Over 50% of the vets said they changed their prescribing as a result of the trial, which we were really impressed. I think it was about 56% that they changed their prescribing. And they really liked the they liked the poster, the traffic light system, and they said the champion was a really just that constant reminder, and they were the most important interventions. And so as a result of that, we've now all of the practices as of the end of last year are now implementing one program, and we have 4 key components and then 2 additional components. And our key components are the guidelines poster, the traffic light system, diagnostic testing guidelines, and having a champion for our 4 key components, and then delayed prescribing and restriction. No, restriction was too hard. They couldn't do restriction because they didn't have somewhere to restrict the antibiotics, and it was too hard with the fluidity of the workforce to have somebody to ask to use. Yeah.
It's very impressive.
Yeah.
Very good. And I love the idea of the traffic light, because, you know, picking up a box that's labeled red is going to really make you think twice, isn't it?
Yeah. And some of the practices went even further and put it up like
higher.
So
Yeah, very good.
visual.
Yeah, very
So
good.
yeah, and that it was.
And you'll know Kristen Reha from Bristol, I'm sure.
Yeah.
Fine. So,
Yeah.
coming back to, is it Minion?
Yeah, so any
Minions
parallels for general
Um,
practice?
So I think the question was around, you know, the whole bundle. And I don't think anyone, to my knowledge, has done the whole bundle. This is a rapidly moving area. So whenever we do a trial, we're aware that underneath there's the secular trend going on the whole time. Stewardship activities are underway. So, you know, that's the reality, and it's a good thing. So we're always seeking to show benefit over and above what's already going on. But no, I haven't done it, and I'm not aware that anybody else has. Maybe you are thinking about it, in which case I say good luck to you, and you might want to talk to people who've done step wedge designs, because that sounds like the sort of design that would be appropriate for that sort of intervention.
No worries. We've gone just a little bit over time, but I reckon if you're happy to sneak in just a
I'm
couple
happy.
more questions. So,
Hey, if you're
Alison.
paying me extra, that's fine.
Yeah. Alison has asked, do you think the increase in concern around group A strep will impact antimicrobial stewardship in primary care?
So the short answer is read my BMJ opinion article published about 4 weeks ago. I don't usually write to the BMJ about that kind of thing, but I did about this because it was a bit of a mess. Overnight, our clinics just filled up with worried parents. Pediatric assessment clinics were totally overwhelmed. So the paradox there is that if you're trying to detect the severely unwell child, it's even more difficult because you've got to sift your way through all of the well children, frankly. So we are expecting to see an uptick in prescribing. We ran out of penicillin, we ran out of amoxicillin, and then goodness knows we were prescribing azithromycin and clarithromycin. So whether we'll see that actually reflected in resistance rates will be interesting, and you might want to stay on for the next talk to see how we might establish if there is an uptick in the AMR rates.
Thank you. And Fiona has asked, have practice nurses been engaged in any of your research work around managing infections?
Yeah, so I think this is a really important topic, isn't it? Because certainly in the UK, and I'm sure elsewhere, we're increasingly involving other allied health professionals in the care of patients with acute infections. And it's not uncommon now for practices in the UK to have nurses, paramedics, pharmacists who are doing the management decisions and seeing the patients. So yes, we do involve them in the study. I think for the dispensing and hospitalization study, there was 25% of the clinicians were non-GPs and the majority of those were nurses. So yes, but I think there are lots of questions outstanding, and it's an important area for us to be focusing on in the future around, we're just handing over responsibility for this. Now, I don't think the GPs amongst us have ever done a great job, but now we're asking other professionals to get involved, and I'm not sure how much we're supporting them, and I'm not sure, we don't even know, I think, whether they're doing a better job than we did or a worse job. All of that, I think, needs to be unpicked. So I think that's really important.
Thank you. And then maybe there's a question in there too from Leslie about the need for parent education as well. Who knows about pain relief options for a child's earache? Does the eBug program help with education, or does UK have other community education or AMS education for health professionals like nurses and pharmacists?
Yes, so lots of elements to this question.
Yes.
So eBug is strongly promoted in the UK, and there have been some really great evaluations. They're not to my knowledge randomized controlled trial evaluations, but good sort of process evaluations showing that they're popular and they increase knowledge. So, that I think does help to make a difference. I think public messaging in general in the UK has changed the environment. I seem to be having fewer arguments with my patients over antibiotics. That might be just because I'm a bit more mature and less feisty, but I think it's because on the whole, our patients are a little bit more aware of AMR, and if you raise AMR as a reason to perhaps reconsider prescribing decisions, they are more aware of it. There was stuff there around pharmacists and training. There's a really big wholesale move to push the management of respiratory and other common infections towards pharmacy and pharmacists. And I think that just goes back to what we were saying before. We don't know if they're better or worse than us. But the other thing that worries me is, remember we were talking about that 8 to 12% who are currently seeking help. If you make a service more accessible, my concern is you're going to just dip into that 80-odd% who are not consulting at the minute, who then think, well, I can quite easily go, so I'll go. And once the patient's in the consulting space, they're at risk of being prescribed an antibiotic when they don't need one. We know that from long, bitter experience. So I think that's the way the policy is going, but those of us who would like to put the brakes on it would like to put the brakes on it for that reason. So the best we can do is roll with it and try and evaluate it and try and see, for example, how much we're dipping into that 80% who are not currently consulting.
Cool. Well, that probably takes us to time for our journal club series. So thank you so much, Alastair. We very much appreciate you
Welcome.
presenting all the research today. And there's a couple claps online. Thanks to everyone online as well. Just flagging for next month's journal club, which we're going back to our regular time of the third Wednesday of the month, 8:30 a.m. The topic next month will be AKIs and AMS in the NT. So a range of presenters there. So look forward to doing all again in a couple of weeks. Okay. And